Let's move on to the next talk on should type 2 diabetics with ESRD be offered kidney alone or SPK. May I invite the speaker, Dr. Peter Stock. I invite the chairpersons for this talk, Dr. Sanjay Sinha, Dr. Vrishali Patil, and Dr. Ashish Sharma. Over to the chairpersons.
Good afternoon. As we now change gears from donation, we move to transplantation, and we have a very interesting session on pancreas transplantation. As the indication for pancreas transplant now include type 2 diabetes, and you have a chance to cure the primary disease. So this talk is going to address the issue whether the type 2 diabetic ESRD be offered kidney alone or a simultaneous kidney pancreas transplant. And to deliver this talk, we have with us Professor Peter Stock, who's a professor of surgery and heads the solid organ as well as the islet cell program at University of California, San Francisco. And to his credit, he has more than 250 publications, numerous awards. And his area of research includes induction of transplantation tolerance to block the alloimmunity as well as the recurrent autoimmunity following pancreas islet cell transplantation. As it is going to be a recorded presentation, may I request the organizers to start the recording.
Thank you for the opportunity to speak about pancreas transplantation in people with type 2 diabetes. The meeting organizers wanted me to address what are the best transplantation options for people with type 2 diabetes and end-stage renal disease, and compare simultaneous pancreas kidney transplantation versus kidney transplant alone in this cohort of recipients. To address these issues, I wanted to talk about the rationale for doing pancreas transplants in people with type 2 diabetes, present retrospective data that is already available comparing patient and allograft outcomes following pancreas transplants in people with type 1 versus type 2 diabetes, and perhaps identify factors that impact the outcomes and identify a subgroup of people with type 2 diabetes that will benefit from simultaneous pancreas kidney transplants. So what is the rationale for doing pancreas transplants in people with type 2 diabetes? Well, for starters, type 2 diabetes is the leading cause of kidney disease in the United States for sure, and probably worldwide. In the US, somewhere around 30 to 40% of kidney transplant waiting lists are made up of people with type 2 diabetes. We know that diabetes control is made worse by kidney transplantation alone and the requisite immunosuppression. We also know from our experience with type 1 diabetes that simultaneous pancreas kidney transplant is the best treatment for insulin-dependent diabetes based on survival and quality of life data. We also know from the type 1 data that adding a pancreas to a kidney transplant does not appear to jeopardize patient survival or kidney allograft survival. Finally, kidney transplant alone in people with type 2 diabetes is associated with degradation of the transplanted kidney, and unchecked diabetes continues to produce both macro and microvascular disease. We also know from the DCCT trial in the United States that even with intensive insulin therapy, hemoglobin A1Cs don't normalize. And the only thing that truly normalizes hemoglobin A1C into the normal range is pancreas transplantation. Of course, we know from the same study that hemoglobin A1C correlates with the development of the very devastating complications of retinopathy, nephropathy, and neuropathy. Finally, this diabetes is a worldwide epidemic. And since I'm speaking to the Indian Society of Transplantation, I thought I would point out that here in Southeast Asia, the incidence of diabetes is growing at a staggering rate. It's expected to increase 84% to impact 151 million people by the year 2045. I also wanted to show this very, very interesting study that shows the high rate of diabetes in immigrants of non-Caucasian background into Canada. Specifically, the study shows a staggering incidence of probability of prediabetes and diabetes in South Asians, Southeast Asians, Sub-Saharan African, and Caribbean immigrants. Now, at our own institution, I can tell you I frequently see Southeast Asian immigrants who are lean, yet have all the complications associated with diabetes. So it's very likely that these ethnically diverse populations are going to see alarming increases in the incidence of diabetes, and resulting in more people with a need for pancreas transplantation. Well, does it make sense to replace beta cell mass in people with type 2 diabetes? Well, we know in people with type 1 diabetes, they've lost their beta cell mass, so it makes complete sense. But does it make sense in people with type 2? It's a heterogeneous disease with multiple etiologies, different degrees of insulin resistance, and different degrees of beta cell mass. Well, the question of transplanting people with type 2 diabetes, it's not really a new question. And Jimmy Light and his colleagues from Washington, D.C. looked in 2013, they reported this. They looked at a 20-year experience of pancreas transplants between 1989 and 2008. And they defined type 2 as fasting C-peptides greater than 0.8. And they found in a cohort of 173 patients, 58 actually had C-peptide. Of the C-peptide positive recipients, more were African American, they were older, they had an older age of onset of diabetes, they had a higher BMI, and a shorter duration of insulin use. What were the outcomes? Well, for the C-peptide positive, the type 2 appearing patients, they had better graft survival than the people with type 1 diabetes. However, the people with type 1 diabetes had better long-term survival rates, presumably related to the comorbidities associated with type 2 diabetes. Very similar data was reported by Bob Strata and his colleagues in 2015. They had a little bit of a stricter definition of type 2. They required a C-peptide greater than 2, and they compared patients with C-peptide greater than 2 to recipients with C-peptide less than that. And once again, they found there was no difference in kidney graft outcome and pancreas graft outcome. And that was a mean follow-up of 5.6 years. So really, they found C-peptide had no bearing on outcomes. Now, what is the U.S. data? It's very interesting. It turns out that we've been doing transplants and pancreas transplants in people with type 2 diabetes. Now, the caveat to this is centers report whether they're type 1 or type 2 without really strict definitions, but presumably they're C-peptide positive recipients. And look at this. Over the last 5 years, the numbers of people getting transplanted that are characterized as being type 2 is now over 20% of the pancreas transplants that are being done in the U.S. I also want to point out that pancreas transplants alone are rarely done in type 2s. That, of course, makes some sense because the indication for doing pancreas transplants in people with type 1 is hypoglycemic unawareness, and hypoglycemic unawareness is very, very uncommon in people with type 2 diabetes. So That explains why it's pretty much limited to simultaneous pancreas transplants or pancreas after kidney transplants. It's also important to note that there's much greater ethnic diversity in the type 2 population than in the type 1. Type 1 is primarily a disease of Caucasians, but you can see that there is a much higher frequency of pancreas transplants being done now in an ethnically diverse population with type 2 diabetes. And this probably accounts for the increase in, at least in part, in the number of African Americans that are receiving pancreas transplants in the US. Now, this is registry data reported to UNOS. These slides are courtesy of Dr. Angelique Grusner. Thank you very much. She maintains a wonderful global registry. This is the US data that shows that patient survival for type 1 versus type 2, this is out 3 years. Look at this, no difference in survival, excellent patient survival in both groups. What about the pancreas graft function? Pancreas graft function out 3 years, 85% reported in both groups. Now, unfortunately, we don't know how they're defining graft success, but let's assume it's the same for both and that there's really no difference. The same with the kidneys that are transplanted in both groups. There is no statistical difference out 3 years in terms of kidney function by diabetes type. And like the outcomes in people with type 1 diabetes, both patient survival and pancreas graft survival are gradually improving in people with type 2 diabetes. And this is looking out several years. Now, there was a much more sophisticated registry study done by Sampaio and his colleagues published in 2011. And after adjusting for risk factors such as obesity, age, PRA, people with type 2 diabetes were not at a higher risk for adverse outcomes. Patient survival, pancreas graft survival, and death-censored kidney survival, all similar between the two groups. So the registry studies show no difference in patient pancreas and kidney graft survival. There are multiple single center studies that also show no difference in patient pancreas and kidney graft survival. I've listed them all here. Similarly, these single center studies don't show any differences in surgical and infectious outcomes, no difference in insulin resistance, and no difference in rejection. However, the studies are limited, and they're limited because, well, first of all, they're all retrospective. There's no prospective studies. Many have variable definitions of what is how to define type 1 diabetes and type 2 diabetes. There are variations in the definitions of what is pancreas graft failure. Some people call it pancreas graft failure if they require an oral agent. Some people say only it's failure if they require insulin. And some people say if there's graft perfusion, it's still a functioning graft. So there are variations in the definitions. There's variable determinations of C-peptide. There's lack of consistent metabolic data, both pre-transplant and post-transplant, including BMI, pre-transplant insulin requirements. And there's also lack of metabolic data post-transplant, particularly concerning the development of insulin resistance and post-transplant diabetes. In order to overcome these, I want to briefly talk about the study that Dr. Orderico, Dr. Pham from the University of Wisconsin, really, they're the leaders in the United States in terms of doing transplants in people with type 2 diabetes, and they were kind enough to share their data. This was actually just published in the American Journal of Transplantation. And it is a retrospective study, but they are very careful to define what's a type 1, a person with type 1 and type 2 diabetes. They looked at recipient factors, including BMI, pre-transplant insulin requirements. They used the UNOS requirements of pancreas allograft failure And they defined it if any of the following occurred: transplant pancreatectomy, relisting, death with a functioning graft, or return to insulin use of greater than 0.5 units per kilogram per day for at least 3 months. One can argue that that's not the best criteria, but that's what we're using now in the US. They also looked at post-transplant outcome of diabetes as defined by the initiation of oral hypoglycemic agents or insulin for a duration of 3 months or greater. And of course, looked at post-transplant outcomes, including the BMI, mean hemoglobin A1C, mean fasting glucose, and maximal fasting C-peptide levels. Using a much more controlled retrospective study in terms of the data they put into it and the output, they saw no differences in patient survival, pancreas graft survival, and this, I don't know if you can see this, but the development of post-transplant diabetes. So I wanted to point out also that, very importantly, they did see that if they use more than 75 units of insulin per day, there was an increased incidence of post-transplant diabetes in the people with type 1 diabetes. So pre-transplant, greater than 75 units per day, higher incidence of post-transplant diabetes. They also saw that if they looked overall in the type 1s and the type 2s, but didn't actually see it in the type 2s alone. But that might just be a numbers issue. The other very interesting thing was that if the BMI was greater than 28, there was an increase in the development of post-transplant diabetes in people with type 2. So there may be some selection here that we should be doing. And when they looked at the metabolic outcomes, they are quite interesting. As the other retrospective series showed, there was no difference in fasting mean sugars post-transplant. The hemoglobin A1Cs normalized within 3 months and stayed that way, no difference between type 1 and type 2. But when they looked at the median fasting C-peptides in the type 2s, they gradually increased over the course of 3 years. Maybe a warning that you're seeing increasing insulin resistance. And similarly, perhaps most interesting, there was a profound increase in weight gain in both the type 1s and the type 2s, but it was much more pronounced in the type 2s, and that may be problematic. That is being seen at many centers, but this is the best documentation of it. So just to summarize the study from the University of Wisconsin, they showed that selected type 2 patients, there's no difference in patient survival, pancreas and kidney graft survival in type 1s and type 2s. The post-transplant diabetes rates are not higher in the type 2s versus the type 1s. However, the high insulin requirements may be a risk factor for early post-transplant diabetes. High BMIs may be a risk factor for early post-transplant diabetes. And these were both seen in some other previous retrospective studies that were reported by Dean and his colleagues from the Mayo Clinic in 2010. The glycemia control, similar in type 1 versus type 2, but there is a greater weight gain in people with type 2s that may be problematic. So I'm going to throw out a straw man based on the study from Wisconsin and all the retrospective studies on what would be the optimal type 2 patient to transplant. Obviously, insulin dependent. We should probably be agnostic to the level of fasting C-peptide, but probably low insulin requirements, less than 1 unit per kilogram per day makes sense. Probably should avoid the morbidly obese and limit it to BMIs less than 33. The recipient should have minimal or corrected cardiac disease, minimal to mild iliac disease, be non-smokers, no current substance abuse, and probably limit it to patients who are uremic. So in conclusion, I would just say that pancreas and pancreas after kidney transplants are being performed with increasing frequency in people with type 2 diabetes. There's similar short-term and long-term risk-adjusted patient survival. There's similar short-term and long-term pancreas and kidney graft survival. Selected patients can benefit with type 2 diabetes, can benefit from SBK. However, the weight gain in the people with type 2 is significant, with evidence for increasing insulin resistance. And there is no question there is a need for prospective randomized trials that hopefully will really hone down on the subtypes of type 2, people with type 2 that will benefit from beta cell replacement, and the mechanisms behind the development of post-transplant diabetes and insulin resistance, and strategies to prevent recurrent disease. So thank you very much. I want to acknowledge John Odorico and his transplant team at the University of Wisconsin, really leading the effort in type 2 diabetes and sharing data with me. And also my own transplant team here at UCSF, the fantastic team that has helped manage our pancreas transplant recipients. Thank you very much for your time.
That was a very interesting talk. As Professor Stock is not available, I would like to ask for any comments from my co-chair, Dr. Patil.
So it seems to be a very important topic for us, especially where we just, even in our country, where there are 44% of patients who are on kidney waiting list are diabetic or diabetic nephropathy. And we do see majority of our patients being type 2 diabetes. And in our country, we see the age of incidence of even type 2 diabetes at a younger age group. So I think Professor Stock's talk on this impact of pancreas transplant type 2 diabetes would go a long way in helping our patients in providing them a better quality of life and better survival. So maybe we could have like a group consensus where we can identify, select a group of patients who would benefit from pancreas transplant in the type 2 group. And that would really go a long way. So I think it was an important talk and an excellent talk on this topic.
So are you currently offering pancreas transplant to type 2 diabetes, or you are restricting to type 1?
No, so we are offering to type 2, and we have a little gone stringent on the type 2 criteria, like the BMI, we are going even less than 25 because we are still a developing program. We initially started with only type 1 and now gradually expanding to type 2. And we are seeing good results. The only, I think, killer or problematic thing is the cardiac disease. So those who have corrected cardiac disease also stand at risk of, that is what we are seeing in our patients, of risk of having cardiac problems like angina or needing angioplasty later on also. So I think if we are stringent in the selection of this type 2 diabetic patients who have not yet developed overwhelming cardiac disease, they would really benefit. In the subgroup of patients that we have done, they have done very well and they have shown good results, comparable results to type 1.
I think it's only a matter of time where this becomes the standard of care, where you will actually offer SPK rather than kidney alone for those patients who qualify for pancreas transplant. I don't see any other questions. So if you have any other comment, or should we close the session?
I think we can close the session. I think it was an excellent talk. And we see a lot of pancreas being rather not used or even wasted. So if you can combine this for a type 2, it would be really good. So thank you for co-chairing this session and an excellent talk by Dr. Peter Stock. So I think we can close the session, sir.
Thank you. Thank you. Over to the ISOT organizing team for the next session.
Thank you, Chairpersons.